This is the Tox Course Podcast. Hello and welcome to the inaugural episode of the new Tox Course Podcast. My name's Andy Buck. I'm the director of the ETM course and our newly launched online course platform, etmonline.com. We're hosting a new emergency medicine toxicology course on etmonline.com. We launched the first Tox Course module late 2023. It's been going for about 6 months now. We've just released module 2. We've literally just finished recording module 3, and we've got module 4 planned to record in around September this year. So the course is going gangbusters. It's fantastic. We decided there's so much good content on it. We wanted to share some of it and really start sharing some of the expert toxicology expertise and knowledge that exists around the country with all of our amazing emergency medicine and toxicology expert colleagues and friends. And we're going to be getting a lot of them onto this podcast. This is a free FOMED podcast that we hope you find useful. And we're going to share a bunch of information on this. And if you like the podcast, please feel free to head over to etmonline.com and check out the new Tox Course modules as they come online. Like I said, Module 1 and Module 2 are out now. All the information's on the website, and we'd love it if you headed over there to check them out. We're going to get started today with my co-creators and the inventors of the Tox Course, really, Ingrid Berling and Nick Dafters, and they're the co-presenters or the main presenters on the Tox Course, and they're going to be talking to us about the Tox system in Australia, all this mysterious stuff that Tox people do and the Poisons Information Centre and how it all works. The guys are going to give us a great insight into that. So we're just going to jump straight into this first episode of the Tox Course podcast, and we hope you enjoy it. Okay, welcome to the Tox Podcast. We're very lucky we've got my co-hosts and co-creators of the Tox Course at etmonline.com, Ingrid Berling and Nick Dafters here. Ingrid, you just want to say hi quickly and tell everyone who you are.
Hi, Andy, and thanks for the welcome. My name is Dr. Ingrid Berling, and I'm a clinical toxicologist and emergency physician working in Newcastle.
Yeah, great. Nick?
Yeah, hi there. My name's Nick Dafters. I'm an emergency physician working with Ingrid up in Newcastle.
Excellent. All right, so we're going to talk today about the Tox system and the Poisons Information Centre service in Australia, because it's this mysterious thing that exists out in the ether that most emergency people kind of know about, and people know to call poisons if there's a funny tox patient shows up in your ED. But a lot of people, including myself, don't actually know how this system works, who staffs it, how it's run, how the calls get through, and who you end up talking to. So, Ingrid, maybe you want to start and just tell us, how does this Tox system work in Australia?
Thanks, Andy. It's actually quite a complicated system, and I think to really understand why it is the way that it is, we need to just have a bit of a think back at the history of toxicology in Australia.
Yep.
And so, back about 50 years ago when the first poison centre started, it came out of a children's hospital setting, which is the way that a lot of poison centres around the world initially started.
Yep.
The reasons that the poison centres started out of paediatric hospitals is because it was paediatric ingestions and poisonings that were causing such significant life threats. This is back in the days before we had tamper-proof tablets, when kids could get access to huge amounts of iron and would die from iron poisonings. So the need and the public interest was in the safety of children. But from those poison centres, they grew this expanding space for toxicology. And that was the original poison centre in New South Wales, associated with the Sydney Children's Hospital. And then the inpatient toxicology service began at a bit of a later date. And that's where Newcastle is one of the founding centres for toxicology in Australia. And back in 1987, Professor Ian White started the inpatient service, basically because it was recognised that there was a need, there was enough patients presenting with deliberate self-harm, and that the internal medicine consultants really weren't overly comfortable or skilled in managing these patients. And so he created this sort of subspecialty field that we now have, and it's expanded as these presentations have occurred all around Australia. And so there's been a need and a development of centres throughout all of the states and territories in Australia.
Yeah, great. So that's a bit of the background. And what does it evolve to now? Because I know there's a few different services in different states. Does every state have their own Tox service, or is there only a few?
So there's only a few, Andy, and we are yet to really develop a national service, but we do all talk to each other and support each other.
So where are they located?
Yep. So the centre, the big centre is New South Wales Poison Centre, which is attached to the Sydney Children's Centre. There's a large poison centre in Victoria attached to the Austin Hospital. WA has a poison centre, and Queensland has an established poison centre that's relatively new, that's happening now as well. So these are the Poisons Information Centres, and this is where you get put through to if you call the Poisons Information number 13 11 26. And that's open to the public and also to clinicians at the bedside in hospitals and anybody that needs information about a poisoning. The inpatient toxicology services are slightly different, and that's where the people who are practiced and skilled at managing clinical toxicology and call themselves clinical toxicologists usually work and reside and see clinical inpatients or patients at the bedside. And those centres are scattered around Australia as well. There's a number in New South Wales. So we have Newcastle, obviously. There's services at Prince of Wales, at RPA. There's services at Westmead and in the western suburbs at Nepean and Blacktown and Mount Druitt. There's also toxicology inpatient services at Princess Alexandria in Queensland. And they've actually also established some virtual outpatient centres. And there are a couple of sites in WA, Fiona Stanley and Charlie's, to name a couple. There's also practicing clinical toxicologists in South Australia and in some other remote sites around Australia. So there's a bit of a service up in Cairns and a new toxicologist working down in Tasmania.
Yeah, great. And how do they interface with the Poisons Information Centre as such? Do you all do sort of on-call work for poisons, or how's the work sort of distributed, or do you just advise or see patients in your local area?
So the clinical toxicologists can work for poison centres, and often they'll work for the poison centre that their state of the state that they reside in. But the way that works to their clinical load is completely different. So the poison centre works by somebody phoning up the poisons number, and the person who answers that phone call is a poisons information specialist. So this person isn't your clinical toxicologist. This is a person who has a special interest in poisonings, has done some extra research and study in that space, and is quite skilled and knowledgeable. And they will manage 97% of the calls that the poison centre gets. So the parent who's accidentally dosed their child too much paracetamol and calls the poison centre for help will be managed by the SPI, the Specialist Poisons Information person on the end of the phone, and they'll manage all sorts of calls.
Ingrid, what is a SPI? Are they generally nurses or not necessarily?
They range from pharmacists to nurses, and it's really open to potentially anyone with a medical health background.
So they're not doctors that take the call, though?
Typically not.
Yeah, so it's a sort of a screening triage process. And again, because these numbers are open to the public, I imagine they must get a lot of calls from all over the place every day with all sorts of weird stuff, and a lot of it doesn't actually need to come to hospital. And then how does the process then work to get put through to a toxicologist as such? And would your average emergency doctor ring up with a straightforward paracetamol overdose or something be handled by the SPI person initially, or would they all get a toxicologist input, or is it depend on the case?
Depends on the case. Certainly there are paracetamol cases that the SPI will feel comfortable managing and give advice for, but anything that's not going down a typical trajectory or is life-threatening or has vital signs or abnormalities that don't quite match the story or that they don't feel comfortable managing will get escalated to the clinical toxicologist on call.
Yeah, great. And when those calls get put through then, so it's something where obviously someone's a bit sicker or needs a medical input, how does that process work? Is there an on-call system? It's people around the country? Is it consultants, registrars? Who takes the calls?
It's a complicated question, Andy, and it differs from state to state and depending on the time of day. Let's assume that most of the time, working hours, each state's poison centre can manage its own region's calls, and any of those referrals would go to their own state's toxicologist who's on call for that poison centre at that time. After hours is a little bit more complicated, and each of the poison centres support each other. New South Wales, being the largest poison centre and the most well-funded, does the majority of the on-calls, so about 50% of all of the nation's calls after hours. But just because that poison centre is the poison centre on call, it doesn't mean that call will go through to a New South Wales toxicologist. If that call's originated in WA, then it will go back to a WA toxicologist that's on call.
Yeah, great. And then I was wondering about, is it all consultants, or is there sort of trainee level people taking the calls as well?
So we in New South Wales have had a established New South Wales Poisons Information Centre fellowship in the last couple of years. So you can certainly have a fellow take the original call that's been escalated up to a clinical toxicologist level referral. And those people are often FASMs. So they've often already finished their first specialty training and are doing extended training in toxicology.
Yeah, great. We might come back to that, I think, to talk maybe about the career pathways for this. That'd be super interesting.
So Ingrid, what kind of calls are you getting at 4 a.m. that, get you out of bed and get you excited to manage from the Poison Centre?
All sorts of calls, Nick, and they really vary in complexity depending on where the calls originated from, whether it's a rural and remote setting to whether it's a tertiary hospital, intensive care, and the skill mix of the providers there that are helping that patient who's taken the ingestion. And they're always interesting calls. It's always fascinating what a patient has been exposed to, what their clinical findings are, and even just problem solving, how to manage them in each of those unique places.
So you mentioned you get calls from remote and rural settings. So how far do you need to get involved with the planning about moving these patients and disposition and retrieval?
So obviously all of that is managed in our state in New South Wales by the retrieval unit, but we will obviously be in joint calls with those services as required because we certainly don't want the patient going to the wrong location. We need to think through whether this patient is going to require escalated levels of care such as dialysis or ECMO, or if they're paediatric, that sort of components of their presentation.
Can you give us some examples maybe of some interesting or, we say fun for medical people, but, the high-end stuff that you get called that really needs your input?
So I guess the ones that that come to mind easily, it's always fascinating to manage a beta blocker or a calcium channel blocker overdose. It's a complicated resuscitation and escalation of the inotropes and vasopressors in those cases, and trying to communicate what's appropriate for each of those unique presentations is important. It's not uncommon for us to get calls about paracetamol and quetiapine. They're still our top two ingestion presentations. And they can still be complicated. So, the simple paracetamol overdose is no longer. Really, there's quite a lot of complicating levels to paracetamol, and even just trying to work through the new Australian MJA guidelines and which patients should have double N-acetylcysteine. It's still an appropriate call and something that often needs assistance. Envenomations are another top call, obviously more in the season for snakes, so the summer months. But they're always a really good call, very fascinating, and often can have life-saving effects with timely interventions with antivenom.
Yeah, great. So have you got any tips for people about, if you're in any type of hospital, really small, medium, large, and someone's thinking about picking up the phone to call Poisons because they think they want to speak to a toxicologist, what information do you want them to have at hand before they pick up the phone to save multiple calls back and forth and, I don't want to say wasting your time, but, drawing out the process? What's a sort of succinct summary for people to have in mind when they pick up the phone, just go, paracetamol, Poisons? No, I think what obviously depends on the exposure, but what's a good set of information for people to have when they call you?
It's always really helpful to have a clear picture of what tablets have been ingested, what milligram size tablets and how many of them have been ingested, whether they're immediate release or slow release, what time they were taken, and what potential other things they might have had access to, and their vital signs this current time. And it's always a bonus if you might know what their respiratory rate and saturations are on room air.
That's a good tip. And we talk about this quite a bit on the course. If people are interested, get onto etmonline.com. We go into this in quite a bit of detail about how to find this information and using all the resources like the paramedic notes and speak to the paramedic, speak to the family, look up their medical records, see what they've got access to. There's a lot of extra information you'll get from the Tox Course online from Ingrid and Nick about this stuff. And how do these calls generally pan out? Again, obviously it depends. There's a lot of variables, but do you find yourself often having to sort of have multiple calls with places or check on patients, or are the vast majority just sort of one-off, here's a bit of advice, follow a plan?
Certainly from the New South Wales Poisons perspective, we are trying to improve the quality of the service that we're giving, and that involves following up the patients and seeing whether the advice that we gave was followed, or whether the patient has improved as we were predicting or does need a second intervention or some more commentary on their management. And that's part of the role of the fellows that we have. So it wouldn't be surprising for people to find that our fellows are calling up about a patient the next day and asking what's going on and what's happened. For us in the middle of the night, it really just does depend on the clinical situation. I would say the majority of calls we only take one call about, but certainly in the really sick and unwell patients, the patients that are deteriorating or continue to deteriorate despite treatment, we will have multiple phone calls about.
Thanks, Ingrid. So you mentioned you do get calls from all around the place and that some of the calls you get are from rural and remote places, and I imagine you do get some calls about snake bites and envenomations, because that's something that I think we often need expert opinion in. And I think, Nick, you had some questions for Ingrid about that.
So we do sometimes find in our hospital where we work that people will bring in snakes or spiders that have bitten them, and often people don't have the animal but are fairly convinced they know what that animal was. But how do you manage that uncertainty when you're getting a call from a remote setting and someone is convinced they've been bitten by a taipan, but we all know snake identification is very difficult? How do you manage that through the Poison Centre?
So we'll touch on this a bit more when we do the envenomation and toxicology modules in Module 4, but we don't rely on patient identification of most snakes. That said, we are relatively comfortable if a patient does identify a red-bellied black snake, being very distinctive type of snake, and with a less severe envenomating syndrome. However, if a patient has brought the snake in with them and has photos, then we would certainly facilitate the clinician forwarding those photos onto us, and it may at times be worth our while to get that photo identified if it's going to make a change in the outcome for the patient. But in the majority of cases, we would follow the snakebite protocol pathway and determine envenomation from pathology tests and clinical markers.
So if you do have a patient who's in a remote location and they're envenomated clinically, how do you go about getting antivenom to that patient?
So each state manages their own stocks of antivenom and life-saving drugs. And in New South Wales, we recently have the life-saving drugs registry, and it will show where each particular site stocks life-saving drugs. So if a patient is in northwestern New South Wales, we can look up where the closest site is that has particular medications that might be of need, including antivenoms. But most hospitals will stock antivenom that are likely to see a snake bite.
There's another area of tox which is relatively uncommon, but again, because it's so uncommon, we don't know much about it. And I often am a bit perplexed is when someone who works in an industrial occupation gets brought in by their manager having had some weird chemical splashed on them or inhaled or somehow exposed, and I don't know, they'll blurt out the name of some weird chemical. How do you guys go about deciphering this stuff and figuring out what it was and what it's going to do to people?
It's a good question, Andy. Certainly as a clinical toxicologist, I am not an encyclopedia of every known chemical and what harm it causes for every patient that might be exposed. And so we certainly get called about things that we have no idea about. And just because you tell me the brand name and the product doesn't mean that I'll suddenly know what it is. But we do have access to databases which do have all this information. And that's part of the value of the poison centres and the National Poisons Registry and the safety data sheets that each of these, big companies are required legally to have about the products that they are using and exposing their employees to. And so it will be, use of all of that information, clues, and access to other information about similar poisonings that we can make an educated risk assessment for the patient.
Yeah, most of the time I find there'll usually be a manager or a supervisor type person there holding some piece of paper with all the chemical information on it, or it's called the safety data sheet, I think. But if they don't, it's important to remember that does exist, and rather than just trying to Google the name of some weird chemical, they can usually get it texted or emailed or sent down to you somehow from someone at the site. So I think it's important to try and chase that information to give to your tox service before you call them. Nick, I think you had some questions about these admitting services and some of the more clinical aspects that the clinical toxicologists get involved in.
So, Ingrid, where we work, the normal practice for admitted toxicology patients is they're generally looked after if they don't need intensive care level care. They will go to our emergency short stay ward under the care of a clinical toxicologist, but we're obviously fortunate to have an on-site clinical toxicology service. Across Australia, how are these patients usually looked after as an inpatient?
It's completely variable to the location that the patient is and how that hospital system and network works. Even within our own network, while we have a hospital that does have on-site toxicologists, there are other hospitals inside our area that will admit those patients under general medicine, typically, if they haven't needed to go to the intensive care unit. And that would probably be the go-to for most other centres, in my experience, in Australia. That said, what we do know over the last couple of decades with these poison centres and toxicology units developing is that the typical toxicology patient's length of stay is on median about 16 hours. And so they really are the classic emergency medicine patient that could be admitted to the short stay unit. And I think as emergency physicians, I think that's really something that we should be advocating to have more of in our emergency departments, and obviously expanding EDs that don't have short stay units to have that capacity.
So Ingrid, do you ever sort of have to provide sort of remote supervision then for these patients, maybe in smaller centres that maybe don't have a FACEM on site, but who either didn't need to or can't get transferred up to a higher level of care?
Absolutely, and there are definitely good reasons why services would call back to the New South Wales Poison Centre or the local poison centre for their states if they need some more clinical input on even help with disposition planning and discharge. Certainly, I think one of my dreams in the future would be that we could expand a virtual tox service. The way that technology is going in medicine, there would be the potential that you really could have a clinical assessment done remotely.
I think there was just an article published this week about that exact sort of idea, a virtual tox service, and maybe we'll put a link to that in the show notes. One thing I've always wondered, and we might wrap up with this, this has been a fascinating insight, is this process of training toxicologists. It seems to be something that's I haven't had much to do with it. It's sort of evolved in the background during my career, the coining of the phrase clinical toxicologist, and it seems like you said, a lot of FACEMs or emergency people are sort of drifting into that. If this is an area of interest for, say, up-and-coming registrars or people looking to do something different with their careers, how do people get into this? And what's the sort of the training and qualification pathway? Who qualifies you as a clinical toxicologist?
It's a watch this space area, Andy, because unfortunately in Australia there's no college that represents clinical toxicologists. But there is a national body called the Toxicology Association of Poisons Network Australia, or the TAPNA Association, which most toxicologists in Australia are members of, and who are currently working on a credentialing process as we speak about what's exactly going to be involved in training in clinical toxicology. It will look something like having worked in one of the inpatient toxicology units and having worked as a fellow for one of the poison centres around Australia.
And so is there any sort of degrees or diplomas or extra qualifications people can sign up for if they're interested in this area?
Yeah, and that is likely to be one of the requirements as well to completing the fellowship. At the moment, we would refer people to the TAPNA course, again, run through the TAPNA organisation, which is a very high level, very complicated, time-consuming course, but really does provide significant detailed information that toxicologist level people will need to know.
And Ingrid, is it just emergency physicians getting into this, or are you seeing other specialties getting involved in clinical toxicology?
Whilst we've certainly seen a huge swing to emergency physicians becoming clinical toxicologists, and I would say currently around Australia the majority are emergency physicians, it's still a space that has people that have completed specialties in intensive care, internal medicine, nephrologists. It's a whole range of people, and it really, a lot of people from different areas can find themselves a place in clinical toxicology.
Fantastic. Look, we might wrap it up there, Ingrid. I think that was just a fantastic overview of the toxin poison system in Australia, pulling the curtain back a bit, I feel like, on this system that we use a lot and people seem to rely on quite heavily, and it's a fantastic service. It does a lot of good for people around the country, and it's awesome to know more about it. So thanks very much.
Thank you, Andy.
And
Thank you.
And if you guys are wondering anything about the Tox course that we've set up, or you want to learn more about any of these specialty areas, the paracetamol overdose we talked about, lots of other things that are available at etmonline.com on the Tox course. Module 1 and Module 2 are out now. We've literally just finished recording Module 3 today, and that'll be out soon, hopefully in the next couple of months. And we've got a really exciting Module 4 coming up with Toxicology, with a very special VIP guest to be announced, but it's going to be awesome. So thanks for tuning into the Tox Course Podcast, and we'll see you in the next episode.